Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all. Hello, listeners, and welcome back to the Heart of Healthcare podcast. Today, we're diving into a staggering $530 billion problem that's hiding in plain sight: medication mismanagement. Did you know that prescription drugs are the third leading cause of death, right behind heart disease and cancer? Around half of those who die have taken their drugs correctly. The other half die because of errors, such as too high of a dose or use of a drug despite contraindications. It's a crisis that affects millions of Americans, yet it often goes unnoticed. To shed light on this issue and share a potential solution, today Michael and I are joined by Yoona Kim, a pharmacist turned health economist turned founder who's on a mission to improve medication management with her startup, Arine. Yoona, welcome to the show.
Thank you for having me.
Let's start by diving into what inspired you to take on this massive healthcare challenge.
Great question. So Arine's focus and mission is to ensure safe and effective medication therapy. And we do this through our medication intelligence platform that can take in all available data from our enterprise customers and turn it into actionable recommendations around who needs a medication change and what should that right drug and dose be. So to go back to why I started the company is basically based on patient experience and what I've seen. I'm a pharmacist, health economist by background. And just to share a story of one of our first patients. So this individual was around 50. He had heart failure and COPD, and he was going in and out of the hospital. We discovered through the data that he was taking 2 or 3 doses of 6 different heart failure medications. And this combination could have led to renal failure and cardiac arrest. So our system alerted these dangerous multiple medications right away. It turned out that he couldn't read his pill bottles and he kept going in and out of the hospital. So every time he would come home, he'd come home with a new set of medications that he started taking. And he thought he was being a good patient, taking all of his medications 100% adherent. So luckily we found this, but this really could have led to a fatality. So this illustrated to me so many broken parts of our healthcare system. There's the data silos where one doctor doesn't know what another doctor is prescribing. There's just the literacy barrier of this individual not being able to read his pill bottles. There's a lack of time that providers experience. They're just trying to get patients in and out of the hospital, and nobody had the time to explain his medications thoroughly to him. And the crux of the reason why I started Arine is because this is the most solvable problem. We just need to get the medications right, and we can make so many people healthier. We can save lives. And at this point in our healthcare brokenness, you can say that prescription drugs are actually killing us in large numbers. And it's the third leading cause of death next to heart disease and cancer.
Wow. Yoona, I don't know how many people can say they are both a pharmacist and an economist. Like, what a cool combo. You are like the perfect person to start this company. That's so neat. Talk to us a little bit about who is your main stakeholder? Who is the organization that you're selling to that is kind of getting this program up and running? And then the secondary stakeholders and the users of the platform.
Sure. So our primary paying customers are the health plans and also the risk-bearing providers, because you can imagine that these interventions can keep patients out of the hospital, reduce complications, and ultimately reduce cost of care. So it's whoever bears that financial risk. The users of our platform include the clinicians, mostly pharmacists and nurses, We've got care managers, health coaches, medical assistants, also users of our platform. We generate recommendations automatically from our platform for both the patient to receive and patient-facing and friendly educational plans, and also prescribers to receive when there is a needed medication change that we are recommending.
How do you get all the stakeholders on the platform? That's, you have to make sure that you're working with, so the health plan, all of the physicians or clinicians that they cover, and then all of their patients.
So the primary users of our platform are those clinicians who are part of that population health care team or affiliates of that health plan. We also have our own clinical care team if our clients need us to supplement. So we also we have our own interdisciplinary care team to provide direct member and provider outreach if and when needed. But majority are our health plans, like population health, care coordination type of teams that are users of our platform. And when we generate a prescriber-facing recommendation, that can be sent electronically from our platform, either via fax, secure email, or directly into EHRs.
I mean, Yoona, taking a big step back, as I think about going to my local pharmacy and I pick up my prescriptions, what's going on today? Is someone not monitoring that, hey, Michael shouldn't be taking this particular prescription with that particular prescription or in this dosage level? What checks and balances? I guess I've naively just assumed when I go to Walgreens or CVS or the local Safeway pharmacy here in the Bay Area, that some master, invisible hand is watching over me on that, but it sounds like maybe not.
Yeah, great question. So there are some checks and balances at the pharmacy, but they are reviewing these interactions or other things without the full context of your medical record. They don't have data on your diagnoses. They only see the prescriptions that you are picking up from a Walgreens, as an example. So from that particular pharmacy chain. In addition, they're also super busy and their main focus is dispensing medication. So they may miss something from a clinical perspective. And in fact, there was a consumer report, a survey that was done that found that 50% of pharmacies actually missed a near fatal interaction. And that's really, again, because of their focus and their primary KPIs are around how many medications can they dispense on an hourly basis. And then you couple that with the fact that pharmacies are now so busy and overburdened. They're giving out COVID vaccines. We have a shortage. So lots of compounding factors as well.
Yeah, it seems to be a common theme that Hallie and I have encountered here in these various discussions with great founders, this clinician burnout factor, right?
Yeah.
Seems to play a part here. So what about so does the Arine platform in being able to access the EHR and say, oh, I see Michael's taking CoQ10 and zinc and this particular medication is negated its effectiveness. Is that an element too? Because, I learn more from time to time from Dr. Google and talking to my great founders who are physicians about, oh, you shouldn't be taking that and that. I'm like, Christ, nobody told me,
Right.
And so is the platform able to pick up, interactions of that sort as well?
Yes. So the platform looks at all the medication related problems that could be occurring. So this could be those drug interaction type of issues. It could be drug disease interactions. It could be you're experiencing unnecessary side effects. It's maybe the wrong drug choice. Maybe it's the wrong drug dose, or maybe it's not, you can get a better, lower cost option that you're not aware of. So it's looking at the plethora of different medication related problems that could be occurring, but it is choosing the right recommendations based on the full context of which medications have you tried and failed in the past. What are your concurrent diagnoses and other social, behavioral, clinical risk factors? And just on that community pharmacy point, community pharmacists, when equipped with a platform like Arine's platform, they can actually perform these interventions at the point of care in the pharmacies as well. And we are doing that with some of our health plans where the main users of our platform are those community pharmacists. And they are doing these interventions when patients come and pick up their medications.
So there was a story in Stat News that I read. The story itself was about the prior auth changes in New Jersey and how that's changing. But to illustrate the problem, they talked about a patient who was denied access to her daily asthma medication that she had been on since childhood. I have asthma. I'm on asthma medication. So the story really stuck with me. But the health plan made her try a different, cheaper generic version and said, you can't go on your old medication until you go on this cheaper one and demonstrate that it's unsuccessful before you can get back on the tried and true version. Well, what happened was she ended up hospitalized for 49 days for life-threatening breathing problems, costing the insurance company way more, and her own health. I mean, that's an insane amount of time in a hospital because they're trying to save costs. And we see this over and over again. How are you, because your tool can enable them to do more of that, right? Like they can just focus on pushing people to cheaper medications. How are you protecting patients?
Right. Great question. Cost is not our primary objective. Our primary objective is appropriate therapy in light of the full patient picture. So when we recommend a lower cost option, because there are a lot of cost optimization, real-time benefit solutions, we are not one of those. Those are geared at reducing prescription drug costs. We are geared at total cost of care picture, keeping patients healthier and out of the hospital, not in the hospital, and not causing complications. And the way that we are different is that when we look at that picture, again, we take into account the full clinical history. How long has this patient had asthma for? Are they being effectively controlled on this inhaler? Can they afford it? It would be a different question. If she can't afford this inhaler at all, then she would need to switch to a lower cost option to stay in control. And is she on the right other medications like long-term controller inhalers? So that is what makes us different than like a cost optimization tool, is that we are looking at that full patient picture and determining which medications that patients can get access to will provide the best health for that patient.
So if a payer came to you and said, we want to reduce the cost of medication for our patient population, that's our only goal, you would say, sorry, we're not the right partner?
We would say we would only do so when it is a clinically appropriate recommendation, and we would want to see the medical claims data as well as the pharmacy claims data so we can make those determinations appropriately.
When you think about it, though, I mean, this has got to be a multi-$100 billion problem, right? When you think about dispensing of incorrect medication or just, mismanagement. So in many ways, this platform is going to save our system. I mean, I'm guessing it's a multi-$100 billion problem.
I'll give you the number, and this was a study published by Scripps. It's a $530 billion problem, and that's the amount of money we spend on prescription drugs as a nation every year. So we spend $530 billion on prescription drugs, and that much, if not more, on the problems that they cause. So Haley, when you ask about, reducing prescription drug costs, that's not where we can save the most money. We can save the most money on just patients being on the wrong drugs, period. Just like that case study that I shared earlier.
And does this come down to the physicians they're not doing their job well? I'm trying to understand how this arises, but we have overuse, underuse, and then misuse, right?
That's right.
And at the end of the day, it's the clinician that's writing the script. What's going wrong there that they're mismanaging this whole process?
So they did do a study, and they found that over 50% of the time, physicians are not reviewing medications. And that is physicians are not medication experts, but in fact, no human is, because they can't keep up with all the medications and then correlate in their mind, this patient's on this medication, but has these 9 others and has these 10 other conditions. And that's why we need the help of technology and a platform like Arine's, because it could put together all this information and do what the human brain can't do, and determine based on all these multifactorial conditions, what's the best medication, and get it right each and every time. Because a human, even if you are a medication expert, simply can't do that. But I think the core of the problem is, like what we saw in that patient case study too, that doctors also are not given the time to do that. People come in for a certain symptom, they get diagnosed for that symptom and treated, and then their time is up and they have to move on to the next patient. Neither do they see all the other medications other doctors are prescribing. So it's a multi-layered problem.
And are you somehow embedding yourself in the EMR so that they're able to see this info right as they're entering the patient information?
Yeah, we are at the point of care with some of our risk-bearing providers where we're integrated into the EHR. With some of our payer customers that are not on a common EHR, we are not, but we still see over 50% of the time providers are implementing our recommendations. And when we first started, we actually went on the ground to one of these clinics who was a high volume clinic. And we said, have you seen some of our recommendations being faxed over to you the old fashioned way? And what did you think when you saw these recommendations? And they actually said, this has been tremendously helpful for us. This is removing work off of our plates. We have to ask all of our patients to brown bag their medications because we simply cannot keep track of everything that they are taking. Neither do we see it in the data. And you're giving us that medication list. You're telling us exactly what to do with our medications. This is helping us so much. And we want to get the medications right, but often we don't have the right information to do so.
And it's not costing them anything to use the tool. Someone else is paying for it. So that's great.
Right.
It's helping them do their job better without adding cost to the already low margin provider business.
That's right.
So challenging. Well, Yoona, you're hitting on obviously one of the hottest topics in venture today and in our ecosystem, AI. And as I think about, that's right, Allie. As I think about, you're identifying all these multifactorial considerations. You're thinking about the human brain and our pattern recognition and processing power between our ears vis-a-vis what all of the exciting advancements in AI have shown. Would love to hear a little bit of how you guys are integrating AI into the Arine platform, how you're thinking about it. There's obviously a lot of concern and skepticism around privacy and what have you with AI, but would love to hear a little bit about how you all are positioning it, thinking about it, and obviously integrating it into the platform.
Yeah, great question. So we've used AI since the beginning days. And the way we do so is we use AI in a couple different ways. One is we use machine learning models to identify who needs that medication change. And the reason why we use machine learning models, so we can take into account hundreds of data features from overutilization of care, underutilization of care, behaviors, risk factors, all of those elements go into our models, and it allows us to have predictive models so we can proactively intervene even when, Haley, we are not at the point of care. And then the other way in which we use AI is now we're using large language models to analyze voice data so we can understand patient sentiment and we can also bring in new data elements that will power our models. So we understand that there are some risks with AI, like with these large language models. There could be hallucinations and other things. So we're quite careful with it. We're not using AI to, like these large language models, to automatically generate recommendations, but more give us insights to feed into our recommendation models. And in general, we have an AI committee here in-house. We test our models for unintentional biases, and we have all the proper practices in place.
How are we going to sustain this? I mean, this year-over-year performance, it's obvious that the product market fit is beyond ideal. How do you think about continuing to grow upon this incredible growth trajectory, and how do we sustain it going forward?
Yeah, so I think in the near term, we can continue this growth trajectory. We've got, 30 health plan customers and plenty of room to expand within these health plans that we have. So our strategy, like many other startups, has been land and expand within these large enterprise organizations. In terms of future growth, we have many more verticals planned for Arine. One is with customers like health systems. They also need to reduce their 30-day readmission rates. They also need to address cost of care because many of them are taking on risk, like through ACO models. And of course, with anything related to hospitalizations, medications are core to reducing hospitalizations and readmissions. And then the other area is what I call working with value-based care channel partners. So if you take any condition, you need to optimize the medication aspects to get to the clinical goals. So we've been approached by home health companies, care management companies, virtual care companies. They have everything else, but they're missing the medication aspects, which are extremely nuanced. So there is an opportunity to feather in our medication intelligence into these other partners. And then lastly, there's biopharma as well, where we can ensure their new drug is being used appropriately in the real world, as well as feedback those data insights on who's doing well on therapy, what the outcomes look like, and that real world performance back to biopharma companies.
Yeah, that last channel is probably going to be pretty exciting, right? I mean, as pressure continues to mount on the pharma industry and as we're hearing about all the talk in Congress and what have you, this has got to be a really, really compelling channel.
Yeah. What we want to do is really strictly remain focused on the outcomes. So our goal is to stay an outcomes focused company. So we can align these entities around the optimal outcomes for any medication therapy.
But something I'm thinking of, if I were to see another smart pill bottle, I would probably just throw it out the window. There's so many of them because, I think the biggest problem with medication adherence is the cost. I imagine most people walk away. You're the pharmacist, so tell us, but most people walk away and don't take their drugs because they can't afford them.
That is one of the core issues when there are, now percentage copays involved with medications. No longer a lot of these flat fees are gone, and now you have to pay 10%, 20% of the drug cost. So that is a problem. And that's, Haley, where we would come in and recommend a lower cost option when it's simply not accessible or affordable for a member.
And Yoona, is that a function of, a partnership with a good RX type, or how do you, obviously generics, and I understand that whole generics versus labeled pricing disparity, but how do you make that recommendation just for our listeners to get a feel there?
Right. So it's plan specific. So during the implementation phase, when we work with health plans, we understand their formulary, their coverage, if they offer one copay for 90 days versus 3 for 30-day supply. We also understand if they have any prescription limits on board, and we actually program these into our software solution. And it's not just the formulary-based recommendations, but also recommendations around the plan's transportation program or how to get connected to a new PCP. So we do everything even around the medications to ensure that members get access to their medications.
Phenomenal. Well, Yoona, this is so cool. Thank you so much for coming and sharing more about Arine. We wish you all the luck. Not that you need it.
Thank you. I do. We all need it.
we wish you to continue to go onward and upward. Thank you
so much. Thank you for having me.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review, and don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.